Dr. Nasir Hussain, who's a senior clinical fellow at Queen Elizabeth Hospital in Birmingham in the transplant unit. And he's going to be talking to us today about approaches to dealing with abnormal liver function tests. Thanks, Nasir.
So I think I'll start with an apology for all of those that are expecting panic. I'm prettier, I hope. So, investigating abnormal liver biochemistry. I won't go into a detailed approach of all the different causes of abnormal liver biochemistry, but hopefully over the next 15 minutes you'll get a systematic approach of how to deal with that abnormal test that you might encounter. And that's hopefully the key. I want to start with why it's important. So I'm certain all of you have encountered that abnormal liver biochemistry test. Now this was a study, I think they looked at all the requests for liver biochemistry in 2003 at the lab in Birmingham, and 67,000 requests, and 15% of those showed an abnormality in one of the parameters for liver biochemistry. And what I find is when primary care requests liver biochemistry tests, you kind of do it because you're doing a routine screen. You're not expecting an abnormality. So when you get this abnormal result, what do I do next? And that's the approach we want to ideally give you today. Why is it important? There's a study that looked at patients who presented to secondary care with end-stage liver disease, advanced liver disease. And over 50% of them demonstrated an abnormality in their liver biochemistry in their past medical records, which suggests that we're probably under-investigating these patients, and there may have been an opportunity to intervene early and maybe change outcome. The other thing is relying on the abnormality to tell us how severe disease is. Now, the degree of abnormality isn't related to the severity of the liver disease. It is in certain situations, but we can see patients who have got advanced liver disease and cirrhosis have very mild changes in their liver disease. So feeling reassured that their level is slightly abnormal and maybe I can just wait on this or sit on this isn't a reassuring approach to take. And that takes me on to the next point. Liver disease doesn't give you any broad and clear symptoms. It develops silently. It's a slow and progressive condition, and patients might not present with any signs of symptoms until it's too late. So that slight abnormality that you might pick up when a patient's asymptomatic and you weren't expecting it might actually do a lot. Finally, just remember common things are common, and that's why there's a separate talk on alcohol and a separate talk on NAFLD. They formulate the two most common reasons people have abnormal liver biochemistry. What I want to focus on today, I guess, is that approach to take in that bottom group, the unexplained group. They don't have a risk factors for alcohol and they don't have a metabolic syndrome. What do we do with these guys? Just a quick recap, and I hope this isn't too basic, but liver biochemistry tests. So gastroenterologists get irritated by the term liver function test because what you're actually testing when you request those are liver enzymes. Liver function is determined best by these three factors. So bilirubin, the liver is responsible for converting unconjugated bilirubin to conjugated bilirubin. So if you see an elevation in conjugated bilirubin, we're thinking about parenchymal liver disease or biliary obstruction. Albumin is a protein that's only produced in the liver, so a good marker of synthetic liver function. However, it's not specific, so you'll have seen low albumin in a range of conditions. INR, so the liver is responsible for producing your clotting factors, and if you've got significant loss of synthetic function, over 70%, you start to see that INR prolong. So it's a late sign, but a key and important sign of somebody that may have advanced liver disease. When it comes to your routine liver blood test, I'll be quite simple and basic here. We want you to recognize the predominant pattern. Is this a cholestatic picture or a hepatitic picture? And when you send your liver biochemistry test, an ALP and a gamma GT are your two markers of a cholestatic picture. So that gives you an idea what the differentials might be. And the only caveat that I note there is the isolated ALP. So ALP is found in abundance in the liver, but also in bone. Gamma GT is not found in bone. So if you've got an elevated ALP and an elevated gamma GT, you can feel reassured that the liver's the origin. But if you've got that isolated ALP and a normal gamma GT, you want to be thinking about the bone and running a bone profile. There's other caveats. Placenta produces ALP. The reference values for ALP vary in pregnancy, but there's other things to think about. The hepatitic picture. So when you do your liver biochemistry test, you don't normally get an ALT and an AST. You usually just get your ALT. It's a more specific marker. It's found in high concentrations in the liver. It's a marker of hepatocyte injury, and it's found in low concentrations outside the liver. AST is less specific. It's found in abundance in muscles, for example. It used to be a marker for heart attacks in the past. But when you get an elevated ALT and an AST, a hepatitic picture is what you're looking at. If you're ever in doubt about whether muscle is the origin, CK is always useful to distinguish. Why do we check liver biochemistry? Well, this study looked at the most common reasons liver biochemistry tests were requested, and it just highlights, so when you do ask for a liver biochemistry test in primary care, you're not actually expecting to find a liver pathology. It could be your routine diabetic review, somebody with non-specific symptoms. So when you do get that abnormal result, you want to have a plan of action on how to deal with it. And this is the guidelines that you can find in the BSG. They're available for everybody to look at. So if you're not familiar with it, certainly a useful resource to have. And it breaks it down on how to approach that abnormal liver biochemistry test. Really useful and really helpful, and a good point of contact to take. And if you hadn't ever heard or seen this before, it's probably one of the key takeaway points. I'm going to touch on some of the important things, and hopefully it helps inform your practice. So when you don't need an algorithm, your urgent cases, your emergency, and hopefully things that you don't need to be thinking about what the cause is, you just need to get on and have an action plan. When you're worried about a malignancy, the painless jaundice patient has really marked cholestasis, weight loss, you get on an organised emergent imaging and refer under the 2-week wait. We've touched on what represents synthetic failure of the liver, so that low albumin and that prolonged INR. They're the patients you don't want to sit on or repeat tests. We need to be getting on and doing an urgent referral, and if they've got features of portal hypertension, like ascites, for example. The emergency case, that's when you want to pick up the phone to the liver registrar or the liver unit or your medical reg, and that's when somebody's got an INR that's creeping above 2, as we've touched on. INR is a late marker of quite advanced liver disease, rapidly progressive jaundice, and then really high transaminases. There's not many things that give you an ALT above 1,000, paracetamol, an ischemic injury or viral hep, but either way, they're things that need acting on quite urgently, so you want to be getting the patient to secondary care sooner rather than later. I'm going to touch on the isolated bilirubin because Gilbert's is relatively common. I'm sure you've seen that mild elevated bilirubin and everything else is normal. Just to make sure you take the right approach, you need to confirm that the bilirubin that's elevated is more representative of unconjugated bilirubin rather than conjugated bilirubin, and you do that by requesting a split bilirubin. Gilbert's is something that's exacerbated by stress, but doing a fasting test will help reveal those elevations more. The only caveat is you should just see a mild elevation in bilirubin. So if they're significantly raised, it's unlikely that Gilbert's is responsible. And also think about hemolysis. So if you've got an anemic patient, run your hemolysis screen or go down the hematology route. So hepatitic or cholestatic, these are the ones that you're going to see and want to come up with an action plan for. The key, I think, is not to make it too complex for yourselves. Don't rely on retesting. It can be quite common reflex thing to do. You didn't expect an abnormality. You probably didn't even request the test. The ALT is a few markers above the normal reference range. Should I just repeat it in a month's time? And this ballot study looked at abnormal LFTs and what they were on follow-up. 84% remained abnormal in a month's time, and over 3/4 remained abnormal in 2 years' time. So it's unlikely to just get better. And that's why you want to determine the cause and focus on it. Retesting should really only be relied on when you feel confident it's a transient rise. You've started a medication which you've withdrawn, or there's an acute illness for which the patient's recovering. So don't just rely on retesting. You've got this abnormal picture, try to think, what is the diagnosis here and what pathway do I follow? The history examination will then be key. Their past medical history, do they have the metabolic syndrome? Alcohol, which we've touched on. Do they have autoimmune liver diseases? Autoimmune conditions that might suggest this is autoimmune liver disease. Risk factors for viral hep. It's going to probably give you the most informative information for you to make the next decision. And I think things probably fall into 3 categories. This is either going to be alcohol, and you go down an alcohol pathway, fatty liver disease, and there's going to be a talk on NAFLD, and it will talk you about the NAFLD pathway, or it doesn't fit either of those. And that's when you want to go through your diagnostic process and think about an extended liver screen. This isn't daunting and it's straightforward, and you can always find access to what is incorporated in a liver screen easily available. Do some basic imaging, and is there a big liver disease, liver lesion that's accounting for the problems? Your viral Hep screen, Hep B and Hep C, if these are positive, you can get on and refer. Iron overload, so a raised transferrin saturation, should get you thinking about doing some HFE genotyping and then referring these patients. Ferritin alone is not specific enough. There's a multitude of conditions that cause a raise in your ferritin. We see it in alcohol. We see it go up in NAFLD. We see it go up in obesity. So relying on that alone is not enough. Your autoimmune liver screen to help you determine whether this is a pattern that fits with an autoimmune liver disease. And then you've got your metabolic test there as well. I've just put in the caveat about PSC. So although PSC is an autoimmune liver disease, it doesn't have any significant associations with any autoantibodies. In fact, a cholestatic picture and a history of IBD is enough to warrant investigating or referring for potential PSC. This is just a study that looked at elevations of ferritin in fatty liver disease, letting you know that it's not very specific, and it's in some cases used as a predictor of the severity of fatty liver disease as well. What I want to do here is try to highlight the disproportionate impact autoimmune liver disease has on the burden of healthcare, especially in tertiary care. So we know liver transplants are increasing, they're on the rise, but I think what's interesting is PSCs being the second leading indication for listing patients for liver transplant. And you'll see PBC and autoimmune hepatitis are in the top 10. So although rare conditions, a significant impact on healthcare services. And for PSC, there's no cure. Identifying these people early, referring them early for clinical trials or assessment is key. So that, and the only clue might be that slightly abnormal liver biochemistry that came up onto your desk unexpectedly. This is just highlighting again how autoimmune liver disease is climbing, and in France a study there suggests that PSC might overtake alcohol as a lead indication by 2025. I think about 1% of the UK population will have IBD, about 20% of those will have PSC. So it's important that we think about it, we look for it, and we refer when necessary. The last slide, hopefully, gives you all a bit of hope. So this is something that we're thinking about incorporating into Birmingham, and if it became nationwide, it'd be amazing. So in Scotland, in this Tayside region, this is something that's live now, but they implemented something called intelligent LFTs. And hopefully, if it is implemented, it's something that means you won't have to hear a talk like this ever again. But what they did was they enrolled GPs, and instead of requesting standard liver biochemistry, they would request intelligent liver function tests. It would be the same standard routine test, but the GP would just put some additional details: their BMI, alcohol status, and diabetes status. The bloods would then go off to the lab and they'd be checked routinely. If they were normal, they'd go back to the GP. However, if an abnormality was detected, an algorithm would automatically use the additional information given to do the secondary test. So these results don't go back to a GP who's then got to deal with an abnormal result, send off a separate set of results, but automatically there and then an extended liver screen would be performed, or a non-invasive liver fibrosis score. And by doing that, the results then go back to the GP with a management plan. You've got somebody who's got likely NAFLD because of a metabolic syndrome, but their non-invasive liver score is low. These are the primary care management things you should be implementing. Or they've got alcohol and significant fibrosis, please get on and refer. Or they've got a cholestatic picture and a positive AMA, refer for PBC. You can see that it increased liver diagnosis by 43%. It's cost effective. It makes the GP's life easier, the patient's life easier, and it makes our life easier. Thank you very much, guys.